The tube thoracostomy or chest intubation shall be performed in the triangle of safety at the level of axilla in the mid-axillary line. Here you can see the anterior border is made by the pec major, the posterior border is made by the latissimus dorsi, and the base is drawn at the level of the fifth intercostal space line joining horizontally both the pec major and the latissimus dorsi. The apex will lie in the axilla. Tube thoracostomy shall be performed at the level of the base in the mid-axillary line. It is very necessary to palpate the space before induction of anesthesia so that we will make incision at perfect level at the upper border of the lower rib to prevent any injury to the neurovascular bundle running in the intercostal space. First of all, we will drape our detected point. You can see here in the mid-axillary line at the level of the base at the in the triangle of the safety. Now we will inject lignocaine 2% at the level of the base deeper down into the space just above the pleura. Lignocaine is used as a local anesthetic as it is short acting and the procedure is also for a short duration. It will relieve the patient from the pain. Now we will mark a horizontal skin incision about 5 cm with scalpel deep up to the subcutaneous space, not into the intercostal space. Control movements on the blade are required, just not to cut the muscles, otherwise they will bleed and make a fuss there. Take a carry artery forceps and make a dissection of the external muscles blindly with the forceps and also with the fingers. Dissect it blindly, not sharply, otherwise it will lead direct to in the injury of the external intercostal muscles or in maybe they collaborate with pleura. As patient was thin, we are now in the intercostal space. Feel with your fingers and then insert your finger. Now fluid is coming out. It means the finger is in the pleural cavity. You can appreciate the pleural fluid is coming out as this thoracostomy was needed to drain the pleural effusion. Chest tube is marked by level of the mid of clavicle to the incision. Hold chest tube with artery forceps and clamp tip before insertion so that negative pressure does not lead the entry of air into the space. We will clamp the tube and directly it upwards to the clavicle with artery forceps in controlled motion into the pleural cavity. We are going down. Just move it slowly, otherwise you will lead to the injury of lungs. Now connect the chest tube to the underwater seal. Do not remove clamp until proper underwater seal is attached, as it will lead to the entry of air into the lungs pleural space. After connecting with the underwater seal, remove the clamp and allow free flow of fluid in the underwater seal. You can here appreciate the movement of yellow color fluid into the drain. Now secure the drain with non-absorbable suture. Apply a vertical metal suture to prevent any skin leakage in the future and also to prevent entry of air into the pleural space. Vertical suture is required as it will be needed at the time of extubation. You can see chest column is moving freely.